Before we start, a gentle reminder to all our attendees. You may type in your questions regarding the lecture in the chat box, and the speaker can answer them in the chat box, or you may personally communicate with the speaker by sending a message to the following email address. Kindly answer the evaluation form after the last speaker of the session. The link will be provided in the chat box. Our next speaker for this afternoon session is Dr. Teresita S. Guia. Dr. Guia will speak on beyond bronchodilation, impact of reducing lung hyperinflation on cardiac function, and health status of COPD patients. Dr. Guia is the chairman of the board of the Philippine Foundation for Lung Health Research and Development Incorporated. She is a fellow of the Philippine College of Physicians, Philippine College of Chest Physicians, American College of Chest Physicians, and the Philippine Society of Critical Care Medicine. She is the executive committee member and national launch leader of Global Initiative for Chronic Obstructive Lung Disease and World COPD Day. She is the former chairman of the Division of Pulmonary and Critical Care Medicine of the Philippine Heart Center, as well as the past president of the Philippine College of Physicians, Philippine College of Chest Physicians, and the Philippine Society of Critical Care Medicine.
Today, we will be discussing beyond bronchodilation. So what happens when we bronchodilate? So here we will show the impact of reducing lung hyperinflation on cardiac function and health status of COPD patients. So this is just a disclosure. And the objective for this particular discussion is to review the multiple effects of lung hyperinflation that is occurring in COPD patients. And we would like to highlight the added benefits of dual bronchodilation on cardiac function. Well, we will start by showing to you what happens that leads to hyperinflation. So hyperinflation that goes on progressively to reduce the inspiratory capacity. Here you see two spirograms, A and B. The A is what we see in healthy individuals, and B is what we see in disease. So we will start with A. What do we expect in healthy individuals? So in healthy individuals, the lung volumes is divided into several types of, shall we say, some form of sections. So the lung volumes, as you could see here, is defined by starting with the tidal breathing, which we do during normal breathing in and breathing out. And you could see there the tidal volume with capacity to maximize inspiration, IC, and also to maximize exhalation, ERV. So here we could see also that no matter during the process of the tidal breathing, the breathing always go back to a stable, shall we say, baseline of inflation. So the stable baseline of inflation is the FRC, the functional residual capacity. And this consists of the ERB, the expiratory reserve volume, that is the amount of air that you could expire further at the end of your tidal volume, and another volume below that, which is the RV, which could not be accessed even sometimes by spirometry unless we do a special test. So those are what happens on a resting individual. Now, what happens when the individual exercise? So in this second part of A, you see a shaded area, which indicate to you now the spirogram that you see in exercising individuals with increase in the ventilatory demands in healthy individuals. So you could see there that there is an increase in the tidal volume and the respiratory rate. So this increase in tidal volume and respiratory rate increases depending upon what is the demands of the activity. Here, to stabilize those particular demands, what the individual does really is to actually use the expiratory muscles so that it will essentially increase the pleural pressure plus the pressure in the alveolus so that the expiratory flow will increase. Now, since this tidal volume are increased, this tidal volume should actually be decreased before the next exhalation comes. So you could see here that at the end of the exhalation, you could see another breathe. So therefore, in these cases, the lung volume becomes stabilized. No? So there is no reason why there should be no stabilization. So this is what happens in the exercising individuals. So in B, you have here a spirogram of patients who have, shall we say, a diseased lung. So this is what happens in hyperinflation. No? In hyperinflation, it is defined really as the amount or the volume of air that is increased during spontaneous expiration. So during the end of spontaneous expiration, we could see in this first part of B that the patient should be able to inhale and exhale. But one thing that is quite apparent here is that the functional residual capacity, or could be called also the end expiratory lung volume, is actually increased. So why is it increased? Well, in advancing age individuals or in patients who have, let's say, starting COPD, there is the connective tissue here becomes damaged, so that there is a decrease in the elastic lung recoil. The decrease in the elastic lung recoil, if you will remember at this particular time, this is the FRC and the end expiratory lung volume increases above the normal, which is what we see in B. So here we have now a FRC in B in which the lung volume is increased to 120, and the residual volume, as you could see here, have increased 2 or 3 times than what you have in the residual volume in A. In A, it's about 30% of the total lung volume, whereas here in B, you could see that's probably almost 100%. So the reason for this, as we mentioned, is the damaged connective tissue, which actually decrease the elastic lung recoil with an increase in the force, the FRC, and the end expiratory lung volume. So this is the consequence of decreasing the elastic recoil, because there will be a retention of air during its exhalation, and therefore at end spontaneous expiration, the lung is, however, becomes now inflated from the loss of elastic recoil. So that is at rest. And what we call this now, the static hyperinflation. Now, what happens on the second part, which is the shaded part? Now, just like what we have mentioned in A, some of these patients, they do exercise. Sometimes they have increased activity so that they have increased ventilatory demands. Especially in COPD, they actually develop this during exacerbation. So you could see here that just like in A, there will be increase in the tidal volume and the respiratory rate. However, you could see now that the presence of the decreased elastic recoil, plus here in the second part, you have also the factor of increase in the expiratory resistance, or shall we say the resistance of the lungs because of the airflow obstruction. So the presence of this decreased elastic resistance plus the, shall we say, the increase in the expiratory resistance, these two factors now increases the time constant of the lung emptying. And this emptying now has been shown in multiple alveolar units to be unequal. And usually the expiratory time that you have during increased demand, which is increased respiratory rate is insufficient essentially to empty each during of the tidal volume during breathing. So that what you could see here, that these two factors now, each tidal volume does not actually empty completely during expiration, and you have an increasing amount of end expiratory lung volume. Another factor here is the fact that just like A, these patients here, they try to compensate by recruiting their expiratory muscles so that they will increase the pleural and the pressure to gain a increase in the expiratory amount of air to be exhaled. However, that does not happen because of the airflow limitation. Sometimes the increased pleural pressure will actually collapse the airway, and therefore there is incomplete, shall we say, exhalation occurring during each tidal volume. So here now you have another factor to increase the expiratory and expiratory lung volume. So if you have now a progressive retention of air, you will note that there is also a progressive increase in the end expiratory lung volume. As you could see there, as the end expiratory lung volume increases, you could see that the inspiratory capacity that is at the end of your graph is now less. So this is how hyperinflation meaning increase in the expiratory and expiratory lung volume could lead to the progression or reduction in the inspiratory capacity, as you could see here. All right, so this is just cartoons to show you what we have mentioned earlier. So this is when the lung is not diseased, and during exercise, you want to increase the pleural pressure, okay, with an intact connective tissue, or when your the tissues of the lungs are not diseased, and you could see that you could actually increase the expiratory flow without any airflow limitation. But this is what happens when you have a decrease in the elastic recoil. So you could see now an alveolus whose integrity had decreased elastic recoil, and even the tissues that is holding the airways open is also diseased and not functioning. No? So that is called the loss of the ring of the airways. So when the individual try to expire, there might be a collapse in this airway. Already there is a airflow limitation because probably of the presence of bronchoconstriction, the presence of airflow obstruction. So that here there is a definite airway dysfunction, which essentially increase the residual volume and the end expiratory lung volume, leading into a dynamic hyperinflation, as we see when there is an air trapping with the progressive, shall we say, progressive retention of air in the alveolus. Now, these findings could also be seen externally when we examine our patient. On the left is a normal patient in which you could see there the dome-shaped diaphragm, which goes up and down during inspiration and expiration through this so-called zone of apposition. This is where the diaphragm in the chest moves, no? So you could see that the diaphragm moves itself up and down to this zone of apposition, which is essentially in, shall we say, sharp angulation. And you could see also that the ribs is diagonal, which is appropriate if you inhale and exhale the lung so that the ribs moves up and down. Now, what happens if you have hyperinflation? You could see that the lung now have an increase in the horizontal diameter and even the depth of the lung. So there is hyperinflation, there's too much air inside the lungs, and therefore what you will see now is that there is a decreased diaphragmatic curvature because this is pushed down by the hyperinflated lung, and now you don't see anymore the zone of apposition, and the fibers of these diaphragms become small, or shall we say shortened, because of it is constantly now in a horizontal position, not in a curvature as we see in the normal. And here you might have impairment of the blood supply. And you will note that the zone of apposition here is also lost. No? It becomes flattened. Sometimes it even become instead of the acute angle that you see in normal, it becomes an obtuse angle. So there are many changes that you see during hyperinflation. The ribs also becomes horizontal, so it's not appropriate to move up and down during inspiration and expiration. So this, when you examine the patient, you see that their chest is hyperinflated and their diaphragms are low. Okay, so there is not much movement inside the chest. Now, what is the natural history of this hyperinflation? Hyperinflation is usually an insidious process, meaning to say it is quite slow, no? It could start as a change in aging, but if you had been, for example, smoking, or you have a genetic susceptibility, or you already have COPD with repeated exacerbation, and the phenotype of your COPD is more of, that is, let's say, will go into hyperinflation like in emphysema, then you will probably have this kind of changes, no? And these changes usually occurs across the continuum of lung severity. And this has been shown even in the early stages of COPD. So from this table, you could see normal spirometry, GOLD 1, 2, 3, and 4, meaning to say the mild, moderate, severe, and very severe COPD, you will note that even if the lung is not so much high emphysematous, the gas trapping, as we have mentioned, with repeated retention of air inside the lung progresses as the GOLD severity also become worse. No? Now, in a study by Hooper, he had shown that this elevation of lung volumes, or so-called hyperinflation, actually could reduce the pulmonary microvascular blood flow as a result of alveolar compression. And he had shown this in these particular images, which have shown that the pulmonary microvascular blood flow actually is already 30% decrease in the mild, and you could see that in severe COPD, there is already a 52% reduction. So these particular changes are more obvious if your phenotype is that of the emphysematous type. No? Now, we are discussing here some other factors that might be beyond bronchodilation, but it might improve with our management of hyperinflation. So this is the effect of hyperinflation on the central hemodynamics. As you know, central hemodynamics begins here with the pulmonary circulation, left heart, and right heart. And then you have the systemic or circulatory circulation. But we will focus on the central hemodynamics, which is meaning to say the right and left heart. No? Now, studies have been shown that the pulmonary circulation, because of the hyperinflation, you have a decrease in the number of blood vessels. As we have shown in the previous study, there is a decrease in the pulmonary microvascular blood flow. Now, the pulmonary circulation will increase in the pulmonary vascular resistance even simply with hyperinflation. No? Now, the right heart, which essentially flow into the pulmonary circulation, as you could see, increase its afterload because of the pulmonary vascular resistance that had increased during hyperinflation. Here, the intrathoracic pressures are increased. You have the juxta alveolar vessels are these vessels that are directly being compressed by the alveolus when it hyperinflates, and also the effects of hypoxia, which essentially vasoconstrict the pulmonary blood vessels. So these will all increase the right ventricular afterload. Now, when the pressure in the right heart essentially overtakes that of the left heart, in what manner will it overtake? Well, because the pulmonary circulation now, which has a decrease, which have an increase in pulmonary vascular resistance, the filling of the left heart, so the left ventricle, will be compromised. So there will be a underfilling of the left heart. There will be decrease in the LV compliance, the cardiac fossa, which is essentially the mediastinum and the pericardium where the left heart is sitting. When the right heart pressure overtakes that of the left heart, you will see that there will be a leftward shift of the septum. This leftward shift of the septum is also helped by the increase of intrathoracic pressures or hyperinflation. And here we have now what we call the increase in the ventricular interdependence, meaning to say that whatever is happening on the right heart could be transmitted as an abnormality on the left heart, especially underfilling of the left heart or the left ventricle. Okay, so these are the clinical consequences of hyperinflation, as we have already shown earlier by the studies. There is a reduced exercise tolerance. So when the end expiratory lung volume increases, so the individual have less room for exercises. They become dyspneic very easily during activity. And oftentimes this could be linked to the disease process like in COPD, which have, let's say, repeated exacerbation. And sometimes it could also be linked to the impairment of the cardiac function, as we have mentioned, if there is an underfilling of the left heart secondary to the increased pressure on the right heart. And this could be independent predictors of COPD mortality. Now, we know the role of bronchodilators in COPD. The guidelines is very specific in telling us that inhaled bronchodilators in COPD is actually central to the management of the disease and should be used regularly to reduce the symptoms, especially dyspnea, let's say, decreased exercise tolerance. Now, the bronchodilators here are either a long-acting anti-muscarinic agents or so-called LAMAs or anticholinergic, and LABAs, the long-acting beta-adrenergic agents. So either of these two could significantly improve lung function by improving the bronchodilation, the resistance, airway resistance during breathing, the dyspnea, the healthy status, and they could also reduce the exacerbation as been shown in studies in LAMAs. No? However, the combination of these two, when given at the same time, will actually increase the FEV1. It will reduce more the symptoms as compared when you are giving just a LAMA or a LABA. So this is the 4-quadrant algorithms that we use in COPD. This is still the same in the guidelines of 2021. And it showed here that the basis for giving the bronchodilators is essentially due to the symptomatology of the patient, as shown here by the MMRC, or the Modified Medical Research Council, which is essentially the classification of dyspnea, and the CAT, or the COPD assessment test, which are a series of symptoms, 8 questions that will tell you actually the severity of the patient's symptomatology, and they are scored, no, in that particular questionnaire. So if your MMRC is 1 or less, and the symptoms that you had collected through that COPD assessment test is less than 10, then this patient is less symptomatic. So you have here the column on the left. The column on the right tells you that the MMRC, or the dyspnea scale, now had increased. Instead of 1, it's 2, in which the individual cannot actually keep pace with people of his same age, and therefore more dyspneic. And the CAT score here is greater than 10. So maybe they had more symptoms like cough, phlegm, shortness of breath, and so forth. So on your right side, this column shows that these are the management for patients who have increased symptoms. Now, the other thing that we look into for giving the therapy is the exacerbation. So now, looking horizontally, A and B have less exacerbation, only 1 or less that had not lead to hospitalization, and the upper C or D, they have 2 or more moderate exacerbation during the past year, or they have only 1 but had led to hospitalization. So you could see if the patient had less symptoms and less exacerbation, group A, you just give a bronchodilator. No? It could be, let's say, a short-acting bronchodilator even. No? In group B, the patient is more symptomatic. However, the exacerbations are less. No? So here you could start with one long-acting bronchodilator. It's either a LAMA or a LABA. No? However, if your CAT score had reached essentially 20 or greater, then this patient, meaning have a lot of symptoms, and therefore you might combine a LAMA and LABA. No? In C, this patient have less symptoms. However, there had been a history of more exacerbation. So we know that LAMA had been shown to decrease exacerbation in some studies. Now D, the patient is more symptomatic and had exacerbation. And you could see here that you might start with LAMA, but if they are very symptomatic, like a CAT score of greater than 10, then you might give them the combination of a LAMA or a LABA. No? Now, if this patient have been shown to have an eosinophils of greater than 300 cells per microliter with the history, let's say, of bronchial asthma, then you might use a long-acting beta-2 agent, LABA, plus an inhaled corticosteroid. So this is how we plan now our management using this particular algorithm. Now, follow-up, we also have used this algorithm. No? If on follow-up, the patient persistent symptoms is more of dyspnea, so if you are giving initially on your left side, if you are giving initially just a LABA or a LAMA, then you combine the two. Now, if the patient had been given a LABA ICS, it's not improving, so you do escalate the ICS and just give a LAMA-LABA. Or if the patient is really symptomatic, then you could give them a triple, but eventually you can escalate the inhaled corticosteroid or ICS and just give them a LAMA-LABA. Now, if this patient does not improve with this combination, then you could either switch a device, maybe it's not the patient's preference, or maybe a change in the molecule and investigate the patient for other causes of dyspnea, like for example, heart disease. Now, if the patient come back to you in 2 weeks or a month or so and still having exacerbation, and if you are only giving either a LAMA or a LABA, then again, you go to the combination. And if you have a patient with a eosinophil of 300 cells per microliter, then maybe they need the long-acting bronchodilator plus an inhaled corticosteroid. But if you had been giving that and they had not improved, you know, they escalate the inhaled corticosteroids and just give them a LAMA-LABA. Or if this patient really is very symptomatic, then you could try giving triple LABA plus LAMA and inhaled corticosteroid. But eventually, when the patient improves, there are criteria in which we could actually de-escalate the inhaled corticosteroid because of the possibility of pneumonias, and therefore you will just have a patient on LAMA-LABA. Okay. Now, if you're giving the patient LAMA-LABA and the patient is still exacerbating, you might consider giving a triple also, LAMA-LABA plus ICS inhaled corticosteroid if the EOS at that point is equal to or greater than 100 cells per microliter. If not, then you can use roflumilast, phosphodiesterase, and especially if the FEV1 is less than 50 and is a chronic bronchitis. So we go now to some of these studies that have shown that the combination of indacaterol glycopyrronium improves the dynamic inspiratory capacity, which we show on this diagram to be actually decreased, no, during hyperinflation. In this particular study by Bay, it showed that for 21 days, they were giving placebo, the combination of indacaterol, glycopyrronium, and tiotropium from day 1 to the day 21, and showed an increase in the inspiratory capacity when they were giving indacaterol and glycopyrronium, which was persistent up to the day 21. No? And it is significantly improved than those who were only taking tiotropium. Now, we go into a very interesting study, which is the CLAIM study, which is the use of indacaterol glycopyrronium in hyperinflated COPD patient. So we would like to know the effect of the lung depletion, okay, with indacaterol plus glycopyrronium on the ventricular filling on patients with hyperinflation and COPD. So we have shown you earlier that there is an interventricular, shall we say, connection, or shall we say, some studies showing that if you have a hyperinflated lung with an increase in the right ventricular, let's say, pressure overcoming the left ventricle, there will be underfilling, might be an underfilling of the left ventricle, especially if you have a pulmonary vascular resistance that is also increasing with loss of pulmonary microvascular blood flow. Here, this study is a double-blind, randomized, crossover, placebo-controlled, but single-center trial. That is the primary objective of this CLAIM study. And secondarily, you have also this other study from this CLAIM, in which you have the indacaterol glycopyrronium, the effect on the pulmonary perfusion and ventilation in hyperinflated patients with COPD, which is an offshoot of the first study. So here they got patients which are 40 years of age with a clinical diagnosis of COPD. They are smokers of at least 10 pack years. And the baseline hyperinflation here, as you could see, as measured by the residual volume, as we have shown to you earlier, that there is an inflation of the residual volume in hyperinflated lungs is 135% of the predicted. The cardiovascular diseases of these patients are essentially stable. They did not have arrhythmias. They have no heart failure, that is ejection fraction of less than 40. And their ischemic heart disease is not unstable. And their hypertension is actually controlled. So 88% of the participants of this study belong to the COPD Gold B. So these are the patients with very symptomatic, however, less exacerbation of 1 or less per year that does not need hospitalization. So this is the study design showing that to show the effect of this LAMA-LABA on cardiac function in patients with COPD with hyperinflation. So essentially, this is not a big number of study. There are about just 62 patients. But here, they were given a pre-screening and a baseline assessment for 3 weeks. And then they are randomized into one group getting indacaterol glycopyrronium and the other group placebo. So they were given for 2 weeks. Then after 2 weeks, they have an assessment and then a washout for another 2 weeks. And then they have a crossover. So those that were taking indacaterol glycopyrronium were randomized to placebo, and those that were initially on placebo were given indacaterol glycopyrronium. Then you have a follow-up period. So it showed that the left ventricular end diastolic volume index, we say, had increased, this the peak, from baseline, okay, to the end of the study, showing that left ventricular end diastolic volume index had actually increased, and those who got the dual therapy of glycopyrronium indacaterol. So it's shown here in the pink shaded bars. No? So the baseline and at the end of the study. So next, they look into the left and right ventricular stroke volume index. So here, they have shown also that comparing baseline to the end of the study, there is actually an increase of the left ventricular and right ventricular stroke volume, more greater, the pink bars, significantly compared to that of the placebo, which is the blue bar. And this is because of the effect of the deflation of the hyperinflation. So you could see here that the hyperinflation at the end of the study showed a decrease in the residual volume as compared on the initial baseline. So the pink, very small bar at the end compared to the blue one, okay, showed that the hyperinflation had actually decreased to that much, which was measured in the form of your residual volume. And then they look into the symptomatology of those patients, and they have shown that the CAT score had actually decreased. We know that the cutoff of the CAT score is 10, okay? So it is decreased from 10, okay, to about 3 score units, so it is significant. And the transitional dyspnea index, which represent the dyspnea score, the MMRC, showed that there is an increase in the improvement in the TDI score when compared with placebo when they were given indacaterol glycopyrronium in these patients who are hyperinflated. So just to show you the effect of decreasing the residual volume, showed here, decrease of residual volume had actually caused the significant improvement of the right and the left and the right end diastolic volume index and the left and right stroke volume. And shown here also is the significant improvement in the symptomatology of the patient, the CAT score and the TDI, decrease in the CAT score and improvement, increase in the TDI score. So in this same study, in hyperinflated COPD patient, the effect on the cardiac function of the dual bronchodilator of indacaterol and glycopyrronium for patients who have COPD and hyperinflated are shown to be multidimensional, which are first, the reduction in the hyperinflation by the decrease in the residual volume. There is improved cardiac function with normalization of the cardiac volumes, a reduction in the symptomatology of CAT score, and the improvement of the health status. And this result actually shows that the use of dual bronchodilator in patients who have COPD and are already showing signs of hyperinflation if you do their lung function studies. Now, as an offshoot of this claim is the effect of indacaterol glycopyrronium in hyperinflated COPD patients, no? The effect on the pulmonary microvascular blood flow or perfusion. Shown in A is the improvement of the regional, shall we say the regional, so the various regions of the lung, I'll plot it there, the right and the left, and it shows an increase in the amount in mils per minute per 100 ml lung volumes, except for the right middle lobe, in which an explanation was not actually given. But if you will look into the coronal blood flow, meaning to say this is the blood flow that is going into the trachea, we have shown here that the use of indacateral glycopyrronium had actually increased the coronal blood flow or the perfusion in that area. And the effect on the regional ventilation, as you could see there, regional ventilation when they were given indacateral glycopyrronium in the yellow bars have increased, and the ventilation defect actually had decreased. The yellow bar on the second B, the yellow bar on the right side, no, compared to the blue side, which it says the effect of indacateral and glycopyrronium. And here is the magnetic resonance images of the microvascular blood flow and the regional ventilation. And as you could see, A and B are the images of the pulmonary microvascular blood flow, and C and D is the regional ventilation. And if you compare the two, you have shown that the yellow spots actually indicate increase in the in B, you know, increase in the pulmonary microvascular blood flow when they were given indacateral glycopyrronium, and D showed the improvement in ventilation or regional ventilation when they were receiving indacateral glycopyrronium. So there is improvement in the pulmonary microvascular blood flow and the regional ventilation of the lung. So in summary, we have shown the expiratory flow limitation, as we have seen, as shown earlier, in the loss of elastic recoil actually leads to hyperinflation. That hyperinflation could be present even in the mild COPD, and it worsens as the COPD severity progresses. And hyperinflation could lead to many consequences. On the lung itself, the dyspnea progression, reduced exercise tolerance, the diaphragmatic dysfunction, and the effects on the central hemodynamics. So, in summary, the benefits of giving dual bronchodilation in the form of indacateral glycopyrronium for patients with COPD and hyperinflation really are multi-dimensional, so to speak. Why? Because it could reduce the hyperinflation, also the symptoms. It could lead to an improved health status, and furthermore, it improves the cardiac function with normalization of cardiac volumes. So this added benefit of the dual bronchodilation on cardiac function can be considered when we are assessing our patients, no? For, let's say, options who are hyperinflated. With that, thank you. Thank you.
Thank you, Dr. De Guia, for that very informative lecture. Again, as a reminder to all our attendees, if you have questions or clarifications, you may type in your questions in the chat box. The speaker will answer your questions in the chat box. Also, please do take time to answer the survey form. The link will be provided in the chat box. The Philippine Foundation for Lung Health Research and Development Incorporated, in cooperation with the Philippine Heart Center Division of Pulmonary and Critical Care Medicine, would like to award the Certificate of Appreciation to Dr. Teresita S. De Guia for being a speaker in the 12th Biennial Symposium, Exploring the New, Novel, Explicable Wonders in Pulmonology, given the 16th day of September 2021 at Quezon City, signed by the organizing committee and the members of the Philippine Foundation for Lung Health Research and Development Incorporated. Please stay tuned for the Pfizer Dinner Symposium at 6:30 to 7:30 p.m. and the Macro Core Bridge After Dinner Symposium at 7:30 to 8 p.m.